Hello, and thank you for joining today's webcast, Practical Application of Nutrition Therapy in COVID-19 ICU Patients, which will be delivered in just a moment by Dr. Arthur Van Zanten and Jennifer Wooley. My name is Lisa Nolan, and I am the Global Clinical Insights and Education Leader for the Anesthesia and Respiratory Care segment at GE Healthcare. I'll be facilitating today's webinar. First and foremost, we send our sincere gratitude to all the clinicians and healthcare industry workers who are on the front lines fighting this pandemic. Our goal is to provide support through educational events like this that may help you as you care for COVID-19 patients, so you may have the best chance of sending them home healthy. Thank you for your tireless efforts and personal sacrifices. Before we begin, we want to cover a few housekeeping items. At the bottom of your screen are multiple application widgets which you can use. I'll briefly cover the most important ones. For those who may benefit from closed captioning in English, you can access them by clicking the CC widget icon at the bottom of your screen. If you have any questions during the webcast, you can submit them through the Q&A widget. We will try to answer as many as possible at the end of today's presentation. You can find additional answers to some common technical issues located in the Help widget at the bottom of your screen. For the best viewing experience, we recommend using a wired internet connection and closing any programs running in the background. Lastly, this webinar recording is the exclusive property of GE Healthcare. No part of the following content may be copied or reproduced without prior written permission from GE Healthcare. Now, without further delay, I'd like to introduce our webcast presentation, Practical Application of Nutrition Therapy in COVID-19 ICU Patients, given by Dr. Arthur Van Zanten and Jennifer Wooley. Dr. Van Zanten is the chair of the Department of Intensive Care and ICU Research at Gelderse Vallei Hospital in Ada, the Netherlands. His research focuses on critical care nutrition with particular interest in immune modulating nutrition, protein needs and timing, mitochondrial dysfunction, and refeeding syndrome. He has been a working member of ASPEN, ASPEN, and ESPEN, developing best practice recommendations. He has authored the chapter on critical care nutrition in the newest textbook of critical care medicine. He has published in numerous peer-reviewed journals and given over 400 lectures on the topics of critical care nutrition and sepsis. Jennifer Wooley is a registered dietitian for 31 years and currently works in the respiratory care segment at GE Healthcare. She is an active member at the Academy of Nutrition and Dietetics and the American Society for Parenteral and Enteral Nutrition. She is a former member of the ASPEN Board of Directors. Currently, she serves on the ASPEN Malnutrition Committee. She has developed her expertise in a variety of clinical nutrition topics, including indirect calorimetry. She is dedicated to the science and practice of providing safe and appropriate nutrition support therapy for ICU patients. Now, I'll pass it over to Jennifer Wooley.
Thank you, Lisa. It's an honor and a privilege to support frontline healthcare clinicians during this pandemic with the practical application of new and timely recommendations for nutrition therapy in critically ill COVID-19 patients. Before we move forward, here's my disclosure. As Lisa mentioned, I am employed by GE Healthcare as a clinical nutrition specialist in anesthesia and respiratory care, specifically working in ventilation. However, I will provide an evidence-based, fair, and unbiased presentation today. Today, Dr. Van Zanten and I want to cover the following topics. Number one, we want to review key takeaways from the new international recommendations on the role of nutrition therapy in critically ill COVID-19 patients. The new recommendations come from two separate sets of statements. The first being from the Society of Critical Care Medicine and the American Society for Parenteral and Enteral Nutrition, and the second coming from the European Society of Parenteral and Enteral Nutrition. Secondly, today, we will discuss the metabolic alterations and impact of COVID-19 on both energy and protein requirements, with the question being, what are the drivers of metabolism in this population? Third, we will use practical nutrition intervention strategies as an example of how you can adapt current guidelines to care for COVID-19 patients, both to provide individualized nutrition therapy and to optimize outcomes. But the question really is, what's realistic and what's effective in these patients? And finally, we hope that you'll appreciate the potential impact of COVID-19 on long-term outcomes. To quote one of our leading authority figures in this arena, are we creating survivals of critical illness or are we creating victims? We want to support the survivors. And with that, we want to first begin with this concept of what are the overarching questions? With COVID-19, we've got a wide-angle lens. The bigger picture is that only 5% of all COVID-19 patients become critically ill requiring ICU stay. A third of those critically ill patients will go on to develop multiple organ failure, and they have a very high acuity level. So it's a small segment of the COVID-19 population that will end up in the ICU, but their needs are very dynamic and require our specific attention. We want to emphasize the importance of both nutrition and safety, not only for patients, but for healthcare clinicians as we move forward. The overarching questions really surround how we execute nutrition assessment in this new ICU environment. How will we use existing guidelines and new recommendations to take our practice to the next step? How do existing guidelines apply to the care of COVID-19 patients? And what approaches will we use to determine energy and protein goals? And finally, the overarching question is, what happens after their survival of the ICU? What about the extended care scene and what happens after hospital discharge? So we need to understand as individual clinicians where our institution is on the curve of COVID-19, as this will affect our daily practice. And then reflect further on, well, of these new recommendations, at my particular institution, you would ask yourself, what are we doing already? What are we good at? And where are our challenges and our barriers? The first set of recommendations comes from the Society of Critical Care Medicine and the American Society for Parenteral and Enteral Nutrition, and that's what I will focus on today. And we really need to distinguish this concept of guideline versus recommendation. So the guidelines that are driving what we're discussing today for COVID-19 patients really came from 2016, when the Society of Critical Care Medicine and ASPEN combined to create their critical care nutrition guidelines, and then in 2019, when ESPEN published their critical care nutrition guidelines. Those have then sprung forth the recommendations that we have today for COVID-19. These are recommendations, not vetted guidelines, but they're taken from the best practices and evidence-based, as well as key opinion leaders to help us during this crisis. The bottom line is that we need to perform nutrition intervention from an evidence-based foundation and recognize that these patients are, quote unquote, in it for the long haul. So we need to be mindful of avoiding cumulative caloric and protein and nitrogen deficits. The first key takeaway that I'd like to focus on from the SCCM ASPEN recommendations is regarding nutrition assessment. So where we're trying to practice safely in avoiding contamination and clustered care, we need to think about what nutrition assessment looks like, because COVID-19 patients are certainly at nutrition risk. Secondly, we need to recognize that timing, route, and dosing matter with regard to nutrition intervention. Taking the first concept with screening for malnutrition, there's typically a mechanism in place for identifying nutrition risk within 24 hours of hospital admission. But once a patient is screened at risk, how does the dietitian or other members of the nutrition support team embark on nutrition assessment? We need to be cognizant of limiting the number of people in the room, conserving protective equipment, and providing clustered care where we batch clinical procedures together to minimize exposure to COVID-19. So this is certainly not the time for nutrition-focused physical examination. This is the time for taking advantage of opportunities to provide remote care or telemedicine, and certainly relying on team collaboration. Because all bedside clinicians, including dietitians, need to check and follow their current hospital policies and procedures regarding going to the bedside versus practicing virtual care and telemedicine in order to keep clinicians and patients safe. Once malnutrition is diagnosed, if the patient is malnourished, we would monitor for refeeding syndrome and start feeding progressively but cautiously in that scenario with a slow ramp up to target. Next, we move on to really the thrust of helping COVID-19 patients, which is dealing with issues around timing, route, and caloric and protein dosing. First, timing and route matter. Enteral is preferred over parenteral nutrition after fluid and hemodynamic resuscitation have occurred. Early enteral nutrition is defined as beginning feeds within 24 to 36 hours of ICU admission or within 12 hours of intubation. The preference for the site of the gastrointestinal tract to initiate feedings is the stomach with a large bore feeding tube, and clustering care with both placement of feeding tubes and abdominal x-rays to confirm placement. Continuous feedings are preferred unless there's a feeding pump shortage. And use of prokinetic agents is an option if patients have intolerance to gastric administration. But repositioning feeding tubes, if that becomes necessary, should take place at the bedside if possible, so that travel and other sources of contamination and exposure are minimized. In terms of tolerance of feeding, the ASPEN-SCCM recommendations are to avoid checking gastric residual volumes to decrease exposure of the healthcare professional to contamination. With signs of GI intolerance, early parenteral nutrition is certainly something to have a lower threshold of initiation. 2 examples of the role for early initiation of PN with GI intolerance are if patients certainly have underlying malnutrition, we wouldn't wait to start parenteral nutrition, or if they're requiring non-invasive ventilation, there may be some increased abdominal pressure, increasing risk for reflux and aspiration. It may be safer, according to the ASPEN-SCCM guideline, to initiate parenteral nutrition. With dosing of nutrition therapy, what is the optimal energy and protein target? Weight-based estimations to calculate energy needs are recommended by SCCM and ASPEN, as indirect calorimetry, although it is the gold standard for determining energy expenditure, is not necessarily recommended due to the fact that not all hospitals have access to calorimeters, and with one calorimeter being used for multiple patients, there is an increased risk of contamination. It's not certain how long it takes to decontaminate a device once it's entered a COVID-19 room. Therefore, weight-based estimations are the first line of therapy for determining energy needs, starting with 15 to 20 calories per kilogram and evolving up to less than 20 to 30 calories per kilogram in order to optimally feed these patients. By starting at a lower target of 25% of calorie needs in refeeding syndrome malnourished patients, then you can ease into the ultimate goal of 25 calories per kilogram. But trophic EN until patients show tolerance at 10 to 20 mLs per hour along the lines of hypocaloric nutrition therapy may be safe to take advantage of using the GI tract, mitigating gut-derived inflammation without overburdening the GI system. In terms of protein, it is recommended to give 1.2 to 2 grams of protein per kilogram, depending on the nutrition assessment and the clinical judgment of the clinician, as well as, in order to preserve lean body mass, thinking about incorporating physical activity as much as possible within your hospital's policies and procedures for this type of therapy during isolation. Moving on to this concept of what are the drivers of metabolism in COVID-19 patients, we can think about it along a timeline. There are different phases in the metabolic response to critical illness related to COVID-19, but we really haven't had a lot of time to actually study and learn about the energy metabolism of COVID-19, so much of this information comes from the sepsis and trauma literature. What happens within the acute response and metabolic response to illness or injury is that there's an acute phase where extreme hypercatabolism and potential loss of skeletal muscle mass and function can occur. These patients can be, believe it or not, hypometabolic while profoundly hypercatabolic using endogenous fuel sources for energy metabolism. This can then evolve into a late acute phase, and if unchecked, move into a chronic phase. And finally, the goal is to have the patient evolve into a recovery phase. But what does the quality of life look like for these types of patients in recovery? Will they have adequate oral intake? Are they able to maintain a nourished state orally in the presence of dysphagia or other debilitating factors? Realistically, how will we monitor the recovery phase once the patient's out of the ICU with limited care? We need to take action by monitoring these patients through telemedicine if possible. It takes a team approach because the bottom line is that many of these patients with long ICU stays end up with ICU-acquired weakness. And we need to continue to attune ourselves and address their needs long after the ICU course is over. But let's take a closer look at these phases of altered metabolism in critical illness. With the acute phase, these are not finite numeric values, they're themes. So the acute phase being days 1 to 2 may be slightly shorter or longer, but it's brief. And in the acute phase, these patients have surging counter-regulatory hormones. They have cytokines and free radicals in circulation that are very conducive to survival, being the first and foremost priority, with the catabolism of endogenous fuel sources to promote that survival. And then the establishment of homeostasis is critical. But ongoing hypercatabolism can take place during the acute phase as far as the late period, lasting as long as 3 to 7 days relative to the patient's individual course. With the altered metabolism of the acute phase, this is very pro-inflammatory, but it can then alternate into phases of anti-inflammation, all driven by hormones affecting glucose metabolism, protein metabolism and turnover, the use of fuels for fuel, energy for fuel, regarding the fact that these patients can be profoundly insulin resistant and they don't necessarily use free fatty acids for fuel normally. So we have a big challenge here, and we don't want to overfeed. We want to support the patient through to the chronic phase. Again, hyperinflammation can continue to surge during this phase, which can then move into inflammation that causes the patient to be vulnerable to opportunistic infections. So it's this pro-inflammatory phase countered by compensatory anti-inflammatory phase that makes feeding these patients so challenging. But what's great is that we have recommendations from the European Society for Parenteral and Enteral Nutrition that addresses nutrition before, during, after critical illness from COVID-19. Dr. Van Zanten will address these statements in more detail and give you his expert opinion, but I will give you an overview here that of the 10 recommendations, 6 are geared toward non-ICU patients and 4 are geared toward critically ill patients. What do both sets of these recommendations have in common? As the clinician at the bedside, you want to take the tools and use the best from both. So as far as the Society for Critical Care Medicine and ASPEN recommendations compared to the European Society recommendations, both sets really have a general foundation of commonality. They have these 6 things at least in common, where nutrition intervention for COVID-19 is considered extremely important, but that malnutrition screening needs to be simple and translate into effective diagnosis and treatment. The concept of enteral being superior to parenteral nutrition is agreed upon in both sets of recommendations, as well as that the stomach be preferred for enteral access and that it begin early within 24 to 36 hours of feeding initiation and admission into the ICU, and that we get to caloric target, at least 70 to 80% of caloric goal by the end of week 1. Both sets of recommendations agree that continuous infusion is favored over bolus infusion for EN, and that it is safe to enterally feed patients in both prone positions as well as those requiring ECMO. The use of parenteral nutrition is indicated to optimize nutrition status in those patients that are GI intolerant to feedings on a case-by-case basis. How are the recommendations different? In C19 patients, in COVID-19 patients, the Society of Critical Care Medicine and ASPEN did not expand on specific malnutrition screening criteria for COVID-19 patients. And the ESPEN statement did recommend 3 options: the MUST, the NRS 2002, or the use of GLIM criteria. Secondly, the European Society recommendations for COVID address nutrition therapy before, during, and after ventilation periods. And another point of disparity that we see in these recommendations is on the topic of whether indirect calorimetry is useful in COVID-19 patients. The Society of Critical Care Medicine and ASPEN stated that due to the guiding principle of clustered care, where patient interactions are limited and bundled together, weight-based equations to estimate energy requirements are recommended as a practical matter, whereas ESPEN stated that IC can be used if safely available with ensured sterility of the measurement system. So, in concluding, what are the bottom line strategies that you can take away today from really improving and individualizing nutrition therapy for COVID-19 patients? We want to translate these recommendations into what you can do for best practice at the bedside. So, yes, nutrition is important in the care of COVID-19 patients. And we want to use a simple approach to screen and intervene on malnutrition and provide early nutrition intervention with adequate energy and protein, avoiding overfeeding while reevaluating energy and protein needs over time. Falling back on the straightforward evidence-based critical care nutrition guidelines that we've used in practice prior to this pandemic. We want to mitigate ICU-acquired weakness by providing optimal nutrition therapy throughout the disease course and work with a multidisciplinary team to develop a discharge plan for nutrition therapy. Our goal is to affirm, validate, and strengthen your clinical practice. And although the changes and challenges of what we're experiencing with this pandemic may be extreme, together we can be triumphant for our patients and for each other. Thank you. And now I will turn it over to Dr. Van Zanten.
Thank you, Jennifer, for this excellent presentation. I'd like to address in my talk the practical applications of nutrition therapy in COVID-19 ICU patients. As you can see in this slide, the typical COVID-19 ICU patient is male, slightly overweight, and many of the critically ill patients need invasive mechanical ventilation. Also, many of them need ventilation in the prone position. And about 10 to 15% need continuous renal replacement therapy. In the initial phase of the COVID ICU stay, many patients need circulatory support with vasopressors, so they're really severely ill. And we will address what to do with nutrition therapy in this webinar. We have to consider when we talk about nutrition therapy that the disease the patients suffer from, the COVID-19 pneumonia, is actually sepsis with multiple organ dysfunction syndrome. So we have problems with the cardiovascular system, so septic shock. There can be problems with the hepatic function, the renal system. Well, many of the patients need renal replacement therapy. Also, the neurological system is affected. In the initial phase, we see a lot of delirium and confusion in the patients. And the main focus is on the lungs, the respiratory system, and many patients need mechanical ventilation. We see some problems in the hematological system also. Some of the patients have disseminated intravascular coagulation, and many have pulmonary embolism or deep venous thrombosis. But nobody is talking about the GI tract. And I think also the GI tract is affected by COVID-19 infection. If we want to optimize the outcome of our patients, we have to consider that the patient is on a journey. And of course, the final outcome is affected by the pre-morbid condition of the patient. And many of these patients already have diabetes or hypertension and are older. So, well, the reserve capacity to recover is diminished in those patients. Of course, also the acute illness is important. How sick is the patient? Now, when you are admitted to the ICU, you're severely ill. And feeding in the face of critical illness is a little bit different than under normal circumstances. The patients have metabolic stress. And that's characterized by inflammation, insulin resistance, persistent catabolism, variations in energy expenditure during the course of their ICU stay and recovery. There can be GI intolerance. They have increased oxidative stress, and there are problems with autophagy in the cells. And of course, after having survived critical illness, we have a long recovery phase. It takes maybe months to years to fully recover, and many patients do not recover to the full pre-morbid condition they had before they came to the ICU. And I strongly believe that the combination of exercise and optimal nutrition is essential to confer an optimal final outcome. So what I'd like to do with you is to address selected topics on the nutrition therapy in COVID-19 ICU patients. So first I will talk about when and how to start enteral nutrition in patients with vasopressors. And then we'll talk about this feeding in the prone position, as many patients are ventilated in the prone position, how to do this, what are the risk factors, and what to do in a situation of high gastric residual volume. And then I will talk about the energy targets, how to set the targets with indirect calorimetry, the VCO2 methods, and can we use equations. And what to do with the neuromuscular blocking agents we use during mechanical ventilation. How does this affect the energy targets? And then I will talk a little bit in the final part of my talk about the targets in the different phases of critical illness, so the early phase until the convalescence phase. Now, first we have to consider when the patient is not invasively mechanically ventilated, but when non-invasive ventilation or maybe high-flow nasal oxygen therapy is used, many consider that the patient can eat normally. But the patients are very sick, and most patients cannot achieve optimal intake during this critical illness, although they're not invasively mechanically ventilated. So in our hospital, we insert a feeding tube in these patients. This can also solve the problem of aerofagia, so that they will swallow some air into the stomach that can lead to vomiting. So it is important also in non-invasively ventilated patients to consider nutrition therapy. But what to do with the ventilated patients, and especially when they're on vasopressors? I was part of a group of the European Society of Intensive Care Medicine. We developed some clinical practice guidelines on what to do with early enteral nutrition in critically ill patients. Of course, this is not about COVID-19 patients, but I think we can learn a lot about how to feed the patients from these guidelines. We know that early enteral nutrition is superior over parenteral nutrition. And the reason is that we keep the gut in a good condition. If we don't feed the gut, it will become leaky. We lose the barrier function, and also the immunological properties of the gut deteriorate. So it's very important to start early with enteral nutrition. But when is it safe? Now, in the guidelines, we have stated in all these conditions presented in this slide that early enteral nutrition is safe and recommended. However, in COVID-19 patients, we have specific situations. We have shock in many of those patients. So when is the shock controlled? And we use neuromuscular blocking agents in many patients. Now, it's safe to do following these guidelines. And in some patients, we need extracorporeal membrane oxygenation, so ECMO. And we have to ventilate the patients in the prone position. So if you listen to the bowel sounds of this patient, many times you don't hear it. But that's not a reason not to start enteral nutrition. And also diarrhea is not a reason to delay enteral nutrition. So in most, if not all, COVID-19 ICU patients, you can use early enteral nutrition. But you have to take into account some reasons to delay enteral nutrition according to these guidelines. And I think there are two important. One is what to do in the patients with uncontrolled shock. So this is in the initial phase or after ICU admission, that maybe the blood pressure is a little bit low. We need vasopressors, and maybe the patient is still hypovolemic. And what to do with the patient with a high gastric residual volume? In this example, more than 500 ml per 6 hours. Now we know from observational studies, and this is one example, that it's safe to feed patients with vasopressors. So in this slide you can see those patients who are fed early, so within 48 hours after ICU admission, that the survival rate was better than when you started the feeding after 48 hours. And this results were also adjusted for the effect of severity of illness. But recently there was this study by the group of Jean Reynier from France, published in the Lancet, and in this study, the NutriRea 2 trial, they compared enteral nutrition to parenteral nutrition. And in this study, all the patients were on vasopressors. And you can see in the bottom part of this slide that there were more gastrointestinal complications in the group with early enteral nutrition. So a little bit more vomiting, but it's also striking to notice that in parenteral nutrition patients, in 24% of the patients still there is vomiting. So it's not only associated with enteral nutrition. But more maybe riskful was that there was also an increased incidence of bowel ischemia and colonic obstruction. But we have to consider that in this study, there was a very aggressive build-up of calories within 24 to 48 hours. The patients were on very high doses of vasopressors. So in this study, it suggests that when the hemodynamics have not stabilized yet, you have to be a little bit cautious with the early enteral nutrition. So what we do in our unit is we always resuscitate the patient with fluids before starting early enteral nutrition, because we want to prevent non-occlusive mesenteric ischemia induced by enteral nutrition. So we give fluid therapy, We start vasopressors, and we wait a little while before we have a stable mean arterial pressure, for instance, above 65 millimeters of mercury, and then we aim for a good blood flow, so an acceptable central venous oxygen saturation and acceptable lactate level, so an indicator of metabolic recovery, so below 2.5 millimoles or at least a drop of 50% from the values on ICU admission. And in our hands, most patients are stable with these criteria within 6 to 12 hours. Maybe in individual patients you have to wait 24 hours, but at least in almost any patient you can start with vasopressors, early enteral nutrition within 24 hours, so meeting the definition of early enteral nutrition. And we did not see any patients with non-occlusive mesenteric ischemia in our unit when we used these guidelines. Now, how to feed the patient in the prone position? Well, there are many observational studies that have studied the gastric residual volume in prone and supine position, and there is not really a difference, so the amount is exactly the same. There are no RCTs on EN tolerance during prone position, but the reported studies do not support withholding EN in the prone position. Gastric emptying seems not to be significantly influenced by the prone position, and adverse events in most studies are not increased. And it's also very likely when being in prone that when there is a regurgitation or vomiting, that this material will go through to the mouth into the bed and not into the lungs. So it's unlikely that you have more aspiration in the prone position. So what feeding tubes to use? We use gastric positioning as a first-line position for feeding tubes, and many COVID-19 patients have excellent gastric emptying, so there's no need to always put the feeding tube in the post-pyloric or jejunal position. So this is also according to our normal routine, start with the stomach. But in patients with an expected prolonged ventilation duration and in patients we need proning, we insert oral gastric feeding tubes to prevent nasal pressure sores or decubital ulcers. And that's something you have to consider after intubation of these patients when you insert the feeding tube. Now, how to check the position? In national protocols in the Netherlands, we use the pH method to check the position of the feeding tube, but it's not very reliable in ICU patients due to failure to secrete gastric acids that can lower the pH, as well as the use of proton pump inhibitor medications. So we check with an X-ray. And as most of our patients get the oral gastric tube placed directly after endotracheal intubation, we only use one X-ray of the chest to check the position of the endotracheal tube and the feeding tube. In this example, you see a patient with a tracheal cannula. It's in the later phase of ICU stay, and you can see the gastric feeding tube in the normal position. Now, what about gastric residual volume measurements? Now, we know that we can stop measuring gastric residual volume. There are some studies indicating that, and in the guidelines it's no longer compulsory. But we believe in our hands, we feel it's still more safe to know what's going on in the gastrointestinal tract, so we still keep measuring it. But then you can use a very high cutoff value of accepting GRV, up to 500 mL per 6 hours. And we do not discard this volume, but we re-infuse this to the patient, not to lose enteral feeding for them. Over this amount of 500 mL, we discard the volume, and then we will start prokinetic drugs. And we use larger bore tubes in the stomach and smaller tubes in the jejunal position. And we don't see many problems with coiling of the feeding tubes. We empty the stomach before we turn the patient into the prone position, or the other way around, from prone to supine. We remove the GRV with the syringe, and after repositioning, we give back the GRV to the patient through the feeding tube. So in general, we interrupt this feeding only for 10 minutes. And when the GRV is below 500 mL, we reinfuse all the GRV, so there's no loss of enteral nutrition. Now, what to do in a situation with a high gastric residual volume? Then we would normally start with prokinetic drugs like erythromycin or metoclopramide following the guidelines. But both drugs can increase the QTc interval on the ECG, as you can see here. And there's one drug, hydroxychloroquine, that's used in many COVID-19 patients, also prolonging this QTc interval. So you have to take this into account. So for that reason, we don't use prokinetics in that situation, but then we would introduce a post-pyloric feeding tube immediately. But when we have stopped this medication for 48 hours, we just use the prokinetics as normal. So take care of the patient with all this combined medication because this can lead to arrhythmia. Now we will focus on energy expenditure. That's very important. And in the recent ASPEN guidelines we have published, I was one of the guideline makers, as you probably will know. We recommended that indirect calorimetry should be performed in all critically ill, mechanically ventilated patients. As an alternative, we can use another technique, the VCO2 from the ventilator, times 8.19. This also gives an indication, and I will come back to that later. So if you don't have a calorimetry device, you should use, of course, the equations, the predictive equations to estimate the energy expenditure of the patient. But they're rather unreliable, and then you should focus on hypocaloric nutrition because we are afraid of overfeeding the patient. It should not be more than 70% of the energy expenditure that is calculated in the initial phase. After day 3, when you can measure indirect calorimetry, you can go up to 80 to 100% of the measured energy expenditure. So if you don't have this device, you have to keep on 70% for the whole first week. So not go higher because there is a risk of overfeeding based on the equations. And the reason is that we have at least 2 observational studies showing that the optimum in the first week of ICU stay is around 70%. If you take the 60-day or in-hospital mortality, you can see that the optimal for calories is around 70 to 80%. So do not overfeed the patient because when you go to like 100% or higher of the target, you see an increased mortality rate. And there are many reasons for that. Probably overfeeding is associated with all these side effects you can see in this slide. And there is even a larger risk when you use parenteral nutrition. Of course, the bioavailability of parenteral nutrition is 100%, and there is no possibility for the patient to produce gastric residual volume or to produce diarrhea to counteract overfeeding. So be careful with also parenteral nutrition. And the reason for this is, as we know now, that in the early days of ICU stay, there is a lot of endogenous energy production. And this energy production cannot be inhibited by giving exogenous feeding. So normally when we start eating, our insulin levels go up and we stop the breakdown of glycogen, muscles and lipid or fat mass. But in critically ill patients who are in a catabolic state, this endogenous energy production will continue although we give exogenous feeding and insulin levels are higher. And this effect disappears over days. So you can see in this slide in the left part, when you put exogenous feeding on top of this endogenous energy production, we can overfeed the patient. And this is the reason that we now recommend to gradually progress to the target in maybe 3 or 4 days. So don't give the full dose to the patient on day 1 or day 2. Now the next question, what formula should we use or what equation to calculate the energy expenditure? The best, of course, is indirect calorimetry. There are many studies showing that all the equations we use are extremely inaccurate. And in obese patients, well, it's said that maybe the Penn State University equation is maybe slightly better. And one of the reasons that this equation is probably better, that it's to use it uses the minute ventilation of the mechanical ventilator. And the minute ventilation of a ventilator, is scheduled by the intensivist based on the CO2 production, because we don't want to have hypercapnia in the patient, and then we have to increase the minute ventilation when the CO2 levels go up. So in a way, as we know that when we burn calories, we produce CO2, that is a reflection of the energy expenditure of the patient. Of course, it's not as accurate as measuring the VCO2 or indirect calorimetry. Now let's focus on indirect calorimetry. It's all based on the wire equation. This is an old equation from years ago, and the resting energy expenditure of a patient can be calculated in kcals per 24 hours when you use this equation, the VO2 times 3.9 and the VCO2 times 1.1. Also important to notice here that the effect of the VO2 is 4 times more important than the effect of the VCO2. It's only 1.1. And if you see the respiratory quotient, that's the VCO2 divided by the VO2. And the respiratory quotient tells you something about the substrate that's used by the patient. So when you use glucose, it goes up to 1.0, and when you use lipids, it goes down to 0.7. So it's a reflection of the substrate utilized by a patient. Now, not everybody has an indirect calorimetry device. So a group from Amsterdam did this study and compared indirect calorimetry with the VCO2 produced by a ventilator. So many ventilators can use based on capnometry can give you the VCO2 or the CO2 production per minute, a reflection of metabolism. And if you take into account, the average RQ of a group of patients, that's 0.86, so the average of substrates that are burned in the patient is 0.86, then you can calculate the VO2 based on the VCO2. So you can see in this slide, if you use the VCO2, you can calculate by VO2 times 0.86. But of course, then your RQ in the patient should be 0.86. So is this accurate? So they compared in this study the VCO2 method with the indirect calorimetry device. And you can see, the accuracy less than 10% or less than 15% is rather high. In the left panel, you see the EE-VCO2, that's the VCO2 method compared with indirect calorimetry. So it's better than Harris-Benedict or 25 kcals or the FACI or the Penn State University equation. So it's better than equations. And also the accuracy, if you take higher cutoffs like 25 or 30%, you can see that there are very few patients who are out of this range when you use the VCO2 method. We did another study, the DREAM VCO2 studies, and I will show you the preliminary results of this study, also comparing the VCO2 method from the ventilator and the indirect calorimetry device we have in our unit. And we compared over 400 measurements from 31 patients to see whether this method is reliable. Now in this slide you can see the preliminary results. In the left panel the Harris-Benedict versus indirect calorimetry, and we also confirm that indirect calorimetry is much better. This is a so-called Bland-Altman graph, and you can see here that the over the ranges of calories energy expenditure per 24 hours of the patients on the x-axis, you can see there is huge variations in the prediction of the Harris-Benedict formulation on the y-axis. So you cannot use the equations very well. And in the right part of the panel, you see the Penn State University. There is also an overestimation of calories by almost 240 kcals per day. So you cannot use the equations. And another technique is, can you improve the RQ in this equation? So VCO2 times 8.19 is kcals per 24 hours. So what about when we use the food quotient? The food quotient you can calculate if you take all the nutritional components of enteral, parenteral nutrition, also non-nutritional calories like from propofol or citrate or glucose or dextrose, and you calculate all those calories, you can calculate the actual food quotient. And we found that it was not so different. The food quotient in our study was 0.90, and measured by indirect calorimetry it was 0.86. So on average, there's not much difference. But if you see that the average RQ in a population is 0.86, and you see the dotted red line, vertical line, that's the 0.6 line, so that's the average of the population. This food quotient predicts this average with a 95% confidence interval. Then you can see that the upper limit is 107 and the lower limit is 0.70. So this range is really huge. So there is so much variation that you cannot use it. And you can also see that the average of a population of 0.86 is very rarely the case. So many patients have much different RQs. Now, what about this VCO2 method compared with indirect calorimetry, the gold standard? Now, if we take a population in the world, the average energy expenditure of the population should be 1875 kcals per 24 hours. That's the red vertical line. And you can see, if you take this average based on the VCO2 method, that the VCO2 method will predict you an intake of 2450 kcals per 24 hours with a 95% confidence interval. The upper limit or the lower limit is 1300 kcals. So in other words, when a patient is having an energy expenditure of 1875, the VCO2 will give you a reading ranging from 1300 to 2450 kcals. So that is a really big range. And it also implies that when the patient has an average of 1875, when you would provide the patient with 2450 kcals, you're overfeeding your patient. So we cannot rely on the VCO2 method. It's maybe better than some of the equations we use, but it's not as good as indirect calorimetry. It overestimates the actual energy expenditure, and the bias and the precision and accuracy rates are, in my view, unacceptably low when you use the VCO2 method in critically ill patients. So I think you all have to buy maybe a ventilator with the possibility of indirect calorimetry or an indirect calorimetry device. When you calculate calories or look at the actual intake of the patient, you also should take into account the non-nutritional calories. So I already alluded to this: glucose, dextrose, propofol for sedation, and trisodium citrate, that's an anticoagulant we use during renal replacement therapy, can provide calories to your patients, and it can be up to 400 or 500 kcals per day. So your dietitians or you have to calculate this amount of intake, because you have to reduce the enteral feeding when you use a lot of these calories. And we did a study on that. And on a population base, it's not so much. It's maybe 10%. But in individual patients, it can be 30% of their daily intake. So be aware of non-nutritional calories and not overfeed your patient. So in the early days in our ICU, we didn't correct for the non-nutritional calories, and that's the left panel. And you can see in this study that many patients during the first week in red were overfed. And after implementation of correction of the non-nutritional calories, you see overfeeding is very rare in our unit. So take into account the non-nutritional calories. Now, what about the neuromuscular blocking agents we used during mechanical ventilation of COVID-19 patients. This is a very recent paper published only a few weeks ago. We did a study and we used the VCO2 method because we want to do a lot of sampling before and after the commencement of cis-atracurine, one of the muscle relaxants. And you can see that the group of patients had a drop in energy expenditure. But the magnitude of the effect was very small, only 6.6%. And we found that patients with sepsis and a higher body temperature had increases in energy expenditure, but the effect of cis-atracurine was very limited on the energy expenditure because we relaxed the muscles. So the heat production or the energy expended by muscles is not that much compared with the overall energy expenditure. And almost none of our patients were overfed due to this effect. So I think it's safe to not change your caloric prescription when you use neuromuscular blocking agents in COVID-19 patients. So you can just keep your targets as normal. Now, what about the intake of our patients in the ICU? This is data from Nutrition Day. That's a worldwide survey among a lot of ICUs, almost 1,000 ICU and 10,000 patients. And you can see that meeting the target of the average population, that is the 1875 kcals per day, it takes almost 14 to 180 days. So many of our patients are really starved in the ICU. That's not probably very good for the recovery, also not in COVID-19 patients. And when the patients are discharged from the ICU to a normal ward, there is only few data available. And this is work from Emma Ridley from Australia showing that when you have a patient on oral nutrition without oral nutrition supplements or without enteral nutrition via a feeding tube, that the actual intake is about 50% for calories and only 40% for proteins. So after ICU discharge, many patients are still starved and on a diet to lose body weight and muscle mass. And in patients with multiple organ dysfunction syndrome in the ICU, we know that the patient loses about 1 kilogram of muscle mass per day. So we have to fight this by giving optimal nutrition therapy in the ICU and also during the convalescent phase in the hospital, but also after hospital discharge. And we also perform a study on this topic, the PROSPECT study, and we monitor the intake of patients after ICU discharge. And we noticed when you take out the nasogastric tube that there is immediately a drop in energy and protein intake in the patient. So it's very important to be very sure to remove the nasogastric feeding tube and not too early, because the intake will drop and this will lead to underfeeding of the patient and more problems during convalescence and rehabilitation. Now, how much food is necessary to recover from starvation? Well, there are no studies in patients or in ICU patients, but we know from the Minnesota Starvation Project, a study that was performed years ago and was, put into the light again by Paul Wishmeyer from Duke University in the USA. And he found that during starvation period, young healthy men in this football stadium in Minnesota were starved in over a few months until they reached a body mass index of 13 or 14. And the starvation period was 1,800 kcals per day. That's what we give our ICU patients. So the patients are on a starvation diet. And if we take into account that it takes a very long time for the patients to meet the target of this normal intake, but the healthy males during the recovery, the receiving phase after this experiment, they were on a diet during 1 year of 2 to 2.5 grams per kg per day, so three times the normal protein intake and 4,000 to 4,500 kcals per day. And they had also an intensive exercise program. And it took about a year for them to recover the body weight, and even the muscle mass was not optimal after 1 year. So if we reflect those data and we, extrapolate this to our patients, we have to give more calories and proteins to the patient during the recovery phase, and we should continue to do this. So I think many patients need enteral nutrition after ICU discharge and at least oral nutritional supplements for a long time, maybe up to 1 year after hospital discharge. So if you want to read more about nutrition therapy and critical illness, not specifically in COVID-19 ICU patients, but I think most of what is in this paper is also relevant for ICU patients with COVID-19. So we wrote this paper, Elisabeth de Waele and Paul Wismeijer and myself, as a practical guidance for the ICU, post-ICU, and long-term convalescence phases. And here you see the summary of it all. So we gradually build up the energy intake during the first 3 to 4 days because of the non-inhibitable endogenous energy production, and we also check for refeeding syndrome. And then during the ICU stay, we go to 100% of the target when we have indirect calorimetry. When the patient is discharged to the ward, we increase the intake of proteins and energy, and when the patient is discharged from the hospital, we go even up to higher targets. So it's important not to stop feeding in the ICU, but to continue optimal feeding also during recovery and rehabilitation. So what I've told you in this webinar over the last 35 minutes, I think we have to start early with enteral nutrition in COVID-19 ICU patients, but after hemodynamic stabilization. It's not necessary to stop the vasopressors first, but after, when you use the checklist I've provided, you can start early enteral nutrition within 24 hours safely. We use oral gastric feeding tubes to prevent pressure sores of the nose, and enteral feeding is as safe in the prone position as it is in the supine position. We gradually ramp up energy and proteins to target in 3 to 4 days, and I have to recommend to you indirect calorimetry. So buy a ventilator with indirect calorimetry features or an indirect calorimetry device separately, because it's superior over the CCO2 method or predictive equation, and it's also recommended by the ASPEN guidelines. Do not forget to include non-nutritional calories in intake calculations. And when you use neuromuscular blocking agents in your COVID patients, there should be no change in the caloric prescription because the effect is only very marginal. You can continue nutrition therapy also after ICU discharge and hospital discharge to improve the final functional outcome of your patients. So with that, I'd like to conclude, and I would like to thank you for your attention.
Thank you, Dr. Van Zanten and Jennifer, for sharing your expertise and insights. For the time we have remaining, we will now address as many submitted questions as possible. While we want to thank everyone for your engagement, unfortunately, we will not have enough time to respond to all submissions. Additionally, please note that the questions and responses may not be relevant in all markets. With that, I'll move to the first question. Dr. Van Zanten, what is your opinion about enteral versus parenteral nutrition during NIV therapy?
Okay, well, I prefer enteral nutrition always as a first-line therapy. So in our ICU, we give the patients always enteral nutrition first, and we don't see many problems with enteral nutrition in those patients with non-invasive ventilation. But if you're not very experienced or you're not able to use prokinetics or post-caloric feeding tubes when necessary in this patient, when they have a high GRV, then of course you can use parenteral nutrition. We know from the literature that, well, compared with earlier studies from a decade ago, the safety of PN is better now. So I think there's no reason to not use PN. But for the reasons I already stated in the webinar, I believe enteral nutrition is superior and should be the first-line therapy. But if you feel that's unacceptable, then you can use PN. But when you use PN, also build up the PN. So not go to the full dose in one day. And that's done, unfortunately, in many cases. So build it up in like 3 or 4 days when it is the initial therapy for your patient.
Thank you. Jennifer, the next question is to you. Do you think the derived Weir equation is useful? What are the limitations?
Thanks, Lisa. The derived Weir equation isn't used very often in the United States, but it is something that has been shown in a number of studies to have better performance than weight-based equations. And it has been shown in a recent study to be as good as the Penn State 2003B equation. But the bottom line is that these equations have high error margins and low rates of prediction and reliability. So they are inferior to indirect calorimetry. Another point is that not all ventilators can calculate volumetric carbon dioxide production, so you need to make sure that your ventilator is capable of giving you VCO2, and this equation can only be used in ventilated patients. So we go back to other predictive equations once the patient is extubated. But the most important part that I think I'd like to mention is with regard to the fact that if you look at the abbreviated Weir equation that drives resting energy expenditure that Dr. Van Zanten pointed out, volumetric oxygen consumption has a great contribution to resting energy expenditure at 4 times that of volumetric carbon dioxide production. So if we're not measuring VO2, we're really missing the biggest driver of metabolism.
Thank you. Dr. Van Zanten, given the different recommendations from the scientific societies, what is your practical advice regarding indirect calorimetry utilization in COVID-19 patients?
Well, I strongly believe that we have to measure the energy expenditure. Recently, Paul Wischmeyer presented some data, some preliminary data from COVID-19 patients in his ICU in Durham in the USA, and he showed that there are huge differences within a patient over days. So it's almost impossible to set targets for those patients based on equations. And well, if you don't have the VCO2, but I showed you clearly from the DREAM VCO2 study that it is inferior to indirect calorimetry, we have to weigh the risk of using indirect calorimetry in COVID-19 patients with respect to transmission of infections to other patients, to over or underfeeding our patients and have a poor outcome with respect of suboptimal feeding. So I think we have to weigh the balance. And if it would be like monitoring the circulation, would you give like an arterial line or measure the oxygen saturation in your patients? Of course you would do it. But it's just a matter that we introduced this technique only recently on a large scale in the ICU. But I think I'm strongly convinced in a few years all ICUs will use indirect calorimetry and have more devices. And what you can do then is put one device in a COVID unit and use another device in the patients who do not have COVID-19. So then you don't have this really transmission risk any longer. So it's a matter of time. I think that we all will use it.
Thank you. Jennifer, should we or should we not check the gastric residual volume?
Lisa, it really depends on your own clinical practice. The European Society guidelines recommend checking gastric residual volumes every 6 hours, even though there is no longer strong evidence to support that. However, the Society of Critical Care Medicine and ASPEN state that out of practicality and clustered care, as well as protection of the healthcare professional and a lack of evidence base behind the value of GRV in monitoring GI tolerance, that they not be checked. So looking at your local environment, looking at the status of the patient and your own comfort level, minimize checking gastric residual volumes and look at other markers of GI tolerance.
Thank you. Dr. Van Zanten, today, what is the role of the respiratory quotient in managing a nutrition plan?
Well, actually, we don't know yet what is the value, but at least when we look at it, when it's very low, when the RQ is 0.7, it could be that the patient is burning a lot of lipids, so it could be that the patient is a little bit underfed. And when the RQ is very high, 1 or a little bit above 1, it could be an indication of overfeeding. But actually, we don't know whether we can manipulate the RQ. But because I showed you in the presentation that most of the RQ measured is based on endogenous energy production, and the effect of exogenous feeding is only limited. So I think it gives you an indication when it's low that it could be an indication of providing too low amounts of energy, and when it's very high it could be an indication of overfeeding. But we need more studies to validate this concept and to know whether we can improve the outcome, focus on optimizing the RQ of the patient.
Thank you. We'll have time for one more question, and Jennifer, this question is to you. What is your opinion about VO2 measurement as a guide to metabolic monitoring of COVID-19 patients?
Thank you, Lisa. I think this is a tremendous asset to be able to monitor oxygen consumption in critically ill patients, especially COVID-19 patients, because after infection, those of the 5% that do become critically ill and end up in the ICU, their deterioration can be very sudden and dramatic. One of the hallmarks of the pro-inflammatory phase that can be profound in these patients is a rising trend in oxygen consumption. It can be quite dramatic. So as a signal or marker of acuity, you could serially monitor VO2 trends as a sign of hemodynamic stability or lack thereof. And I also want to point out that in the respiratory quotient equation, it's VCO2 divided by VO2. So anytime oxygen consumption is high, you're going to have a higher denominator being divided into carbon dioxide production, resulting in a very low respiratory quotient, despite whether or not you're under or overfeeding your patient. So yes, I think VO2 is very valuable, not only as a marker of energy expenditure, but as a marker of the hemodynamic excursion that the patient might be undergoing.
Thank you, Jennifer. We are now ready to conclude this webcast. We appreciate you taking the time to attend, and more importantly, thank you for all you are doing to care for COVID-19 patients battling this disease. Lastly, I'd like to mention in the resources widget on your desktop, you can find a link to GE Healthcare's ICU ventilation resources webpage, which provides details on how to operate the CareScape R860 ventilator, along with weaning and infection control resources. Thank you again, and stay well.